ASH 2015 coverage in Orlando. Thomas Baldrick, joined now by Dr. Jeffrey Weitz from the McMaster University in Hamilton, Ontario, and here to talk about latest advancements in treating major bleeding. Thank you, doctor, for joining us. In the past couple months in the New England Journal of Medicine, there's been a couple of important publications on this subject of major bleeding. Can you give your opinion of those?
Well, as you probably know, we've moved in the last few years from the use of Warfarin or other vitamin K antagonists to these new anticoagulants. And these new anticoagulants come in two flavors. We have dabigatran, which targets thrombin, and we have three oral factor Xa inhibitors: apixaban, rivaroxaban, and edoxaban. So one of the missing links in our management of patients with these new agents has been the lack of an antidote. Now, there's been a concern that if patients have serious bleeding, if they're involved in trauma, if they need urgent surgery, how do you reverse these anticoagulants? They have a short half-life, so time is on your side if you can wait it out, but sometimes you just can't wait it out. So what has happened in the last few months, and what you're referring to with these two papers, on the side of dabigatran, idarucizumab was introduced. It's now known as Praxbind, and this is a monoclonal antibody fragment that binds dabigatran with high affinity and removes it from the circulation. So now you can give this as an intravenous bolus, and the anticoagulant effect of dabigatran goes away and stays away. So that is phenomenal for reversal of dabigatran, and this study was done in patients who presented either with life-threatening bleeding or who presented requiring urgent surgery or intervention. On the flip side, the more recent paper looked at andexanet alpha, and this is a reversal agent that will reverse the oral Xa inhibitors, apixaban, rivaroxaban, edoxaban. And what they did in that study is, this was not a patient study, this was a volunteer study. They gave volunteers either apixaban or rivaroxaban. They showed that it had the expected anticoagulant effect, and then they gave the volunteers either andexanet or placebo. And they showed that the andexanet reversed the anticoagulant effect of apixaban and rivaroxaban, brought it right down. That drug is given as an intravenous bolus followed by an infusion, because once you stop the bolus, if you don't give the infusion, there's a rebound increase in anticoagulant activity. So the difference between these two studies is one focused on patients who are bleeding or who required urgent surgery. The other one is really a study in volunteers just to show that you can reverse the anticoagulant effect.
What do you think the clinical implications of these new agents are or will be?
Very important clinical implications. So for Praxbind, it's now licensed in the United States. It's already being distributed to emergency departments around the country. So this means if a patient on dabigatran came in with multiple trauma, you can give Praxbind, reverse the anticoagulant effect, and then you can get on with your business to take care of the trauma. Or if someone came in and they needed urgent surgery because they fractured their hip, you can reverse the dabigatran and get on with it. For andexanet, we're a little farther behind. Now they are doing a study in patients taking these Xa inhibitors, looking at its capacity to reverse it in people who are bleeding. So we'll have more information, but we don't have any patient information. It's all so far in volunteers. But when we have both of these in our emergency departments, in our hospitals, we'll have closed the loop. We've had these new agents, they're great, but there are times when we need a bailout. We'll have Praxbind for dabigatran and andexanet for the oral Xa inhibitors.
So you would really see these having a major impact going forward?
Absolutely. I think it's more a psychological impact. There aren't that many patients who require reversal, but having it is huge, because one of the barriers to uptake of these new agents has been patients ask, well, what do I do if I get into trouble? And you have to say, well, we don't have any antidotes. Now they can be reassured that, no, we've got that extra safety net if you need it. But overall, bleeding occurs less frequently with the new agents than with warfarin. And we have data from the clinical trials that if a patient has a major bleed, even in the absence of the antidotes, they don't do worse with the new agents than with warfarin. In fact, they might even do a little bit better. But now we can get this whole thing off the table, and we'll have these rapid reversal agents. So I think the only challenge going forward is these are not cheap, so we'll have to use them appropriately. And we'll have to develop systems of care, pathways of care to make sure that they get to the right patient and they're not overused.
Exciting times.
Very exciting.
Thank you, Dr. Weitz. Appreciate your time.